Good afternoon. My name is Giammarco. I'm doing my first year of postdoc at the University of Florence. I would like, first of all, to thank Julia for inviting me to talk for this seminar. And I would really like to use this opportunity to present a new study that I'm doing with Eleonora Trappolini from Coca University of Milan. It is absolutely a work in progress. So the point is we were supposed to present this at the EPC conference in Padova, which unfortunately will not take place due to the current situation. So assuming that there won't be many other conferences during the rest of this year, I invite you to please share your comments and suggestions, and that would be particularly appreciated. So Eleonora and I defended our PhDs last February. Her thesis was about migrants' health. My thesis was about fertility. And let's say that this is the first attempt to pull together our knowledge on our research topics to talk about something new, or at least something that has been under-investigated so far. Our study is titled Better Health, Higher Fertility, and we aim to explore the relationship between migrants' health and fertility intentions in Italy. Okay, I'm not wasting time describing the outline because this is just the most classic outline that you could ever imagine for a short seminar about a study, and I'm moving to the introduction. I would say that migrants' fertility has always been a prominent topic in demographic research, ever since demographers have studied migration flows. The interest for this topic was renewed recently, especially in the European context, probably for two reasons. The first is the persistence of low fertility rates in many countries. It was called the lowest low fertility during the 90s, and not much has changed since then in many European countries. And the massive increase is the second reason, is the massive increase of migratory flows towards Europe that took place during the same years. In this scenario, the contribution to the total fertility made by migrants became more and more important, but migrants' health has never entered the debate on migrants' fertility. So what is known about migrant fertility? Well, there are many theories that explain fertility of migrants after migration, and empirical evidence is quite abundant, but not for Italy, actually. Studying migrants' fertility, researchers found that not all migrant subgroups display higher fertility rates than natives, than their native counterparts. There are significant differences according to the country of origin, according to the country of destination, according to the socio-economic status, and also the duration of stay is important in the destination country because it was found that migrants' fertility usually peaks right after migration, especially in cases of family unification, but also that migrants' fertility tend to converge towards natives' level of fertility as the duration of stay increases. And last point, also the reason for migration is an important factor, and there are clearly many others. To our knowledge, none of the existing theories includes explicitly health among the main determinants of migrants' fertility, and existing studies have never tested if whether health status has an effect on migrants' fertility directly. Even if it has never been considered among potential determinants of migrants' fertility, migrants' health is a quite important topic in demographic research. And several studies found that migrants usually display better health conditions than natives. And they also tend to have lower mortality rates. And this is probably, in our opinion, why health is not considered as a potential barrier to migrants' fertility. So why should health be considered among fertility determinants if their health is on average so good? The most relevant theories explaining migrants' health advantage are the healthy migrant effect, according to which migrants are a selected group of people with quite good health conditions, which makes them suitable for migrating. Then there is the Salmon bias, and also the data artifact can explain migrants' better health in some cases because registration errors relating to moves between the origin country and the host country can mismatch deaths and risk population. And as a consequence, there is a denominator bias and underestimation of migrant mortality. But let me go briefly through the parts of the literature that might relate closely to migrants' health and fertility. So I say that migrants tend to have good health, even better than natives. Nevertheless, it was argued that in some cases, migrants tend to lose their health advantage as the duration of stay in the destination country increases because of negative assimilation and or persistent low socioeconomic status. Migrants' health may also differ by country. Among the few comparative studies for Europe, there is this one by Moulin and Juzot, 2014, showing that migrants have poorer health than natives in France, Belgium and Spain, while the opposite was found for Italy. And this is in line with what I have just said about length of stay, considering that Italy is the country with the shortest migratory past in that club. Migrants' health disadvantage changes also between genders. There are studies showing that women tend to declare worse health than men in general, and that such differences persist also within migrants. And one last point regards the reason for the migration. Well, migrant women seem to be less selected on health than men, especially when they migrate for family unification, and they lose their health advantage at a faster rate compared to men. So I talked about fertility, I talked about health. Let's see if the relationship between fertility and health has ever been studied. There are studies that found a significant relationship between the two dimensions, especially among women. Women with the health problem tend to desire and then to have fewer children than healthy women. And there might be several explanations for this. For example, health problems might cause infertility, or curing a disease might be contraindicated during pregnancies, or again, women might be worried about the effects of pregnancy on their disease. However, these studies mainly come from the medical field, and they address usually specific disease. So there are virtually no demographic studies that consider health status as a potential determinant of fertility, and moreover, there is no specific evidence on the case of migrants. So our research questions are quite straightforward. We wonder if there is a relationship between health status and fertility among migrants, and if yes, which factors moderate such effect. I'm talking about the classic factors such as gender, the length of stay, or the country of origin. We choose Italy as a case study because it displays a certain number of interesting features. For example, it is a country with a relatively recent migratory past, and it's been among the countries with the lowest fertility levels in the 90s, and it still displays low fertility. And there is scarce evidence on migrants' fertility and on migrants' health. The only data set that would allow us to explore the relationship between the health dimension and the fertility dimension among migrants is a survey called Social Condition and Integration of Foreign Citizens. It was carried by the National Institute of Statistics. It's not really brand new data, but they released some nice variables that can be used in analysis lab hours. And at the same time, it lacks some critical information. But since there is no longitudinal data on migrants in Italy, we can't use a longitudinal approach, for example, implementing event history analysis. So we have to rely on fertility intentions, which are an immediate measure of fertility, and they were proved to be good predictors of actual fertility. And finally, they have already been used to study migrants' fertility too. As a health measure, we use self-rated health, which is a widely used indicator. It was proved to be a good predictor of mortality, and it was shown that it can be used as a valid health indicator also to compare different ethnic groups. Our main variables are the fertility intentions in the classic 4 category variables that goes from definitely not to definitely yes, answering to the question, do you intend to have a child in the next 3 years? And self-rated health, which we transformed into a dummy, distinguishing between those who declare very good health, which is our one, from all the others. This was the best option in order to have a balanced in order to have two balanced subsamples. As I said, despite some limitations, the survey provides some really good covariates. Clearly, we have the classic demographic variables such as age, the civil status, educational level, the number of children, and so on and so forth. Plus, we have the length of stay in the host country, which allows us to distinguish between recent and long-term migrants. And we choose 6 years as a threshold because we have it categorical. So this was the best compromise. We can control for the occupational status and for the country of origin, but as regards the latter variable, we have geographical groups of countries, which is not the very best option, but still, it allows some sort of control on this important aspect. And moreover, we have questions about the reason why the respondent has migrated, and we try to group individuals into 3 categories. So those who migrated for economic reasons, those who migrated for affective reasons, and all the others. We have roughly 4,000 men, women, and 3,000 men. So as regards the methods, first we thought about using regression models for categorical variables such as logit or probit or ordered probit or ordered logit, but to see if and how self-rated health affect the probability of declaring positive or negative fertility intentions, controlling for a set of variables of covariates. But then we thought that this approach was probably a bit simplistic and that our estimates then could have been biased because fertility intentions and self-rated health are 2 subjective self-reported variables, and thus there might be unobserved factors that influence simultaneously both spheres. So the sphere of intention in the fertility sphere and the sphere of health. Yes, for example, just simply individual attitudes may influence both dimensions. And with this model, which is with the model that we are going to use, which is called bivariate ordered probit model, this model consists in a set of 2 equations concerning self-rated health and fertility intentions. So first, an equation is for self-rated health is estimated, and then the outcome of the first equation is included as a covariate in the second equation, the one about fertility. The error terms are jointly normally distributed and thus correlated. So in the system of equation, if you see the second equation, gamma represents the effect of self-rated health on fertility intentions after adjusting for the presence of unobserved characteristics. So in few words, what we are doing is taking into account the endogeneity between self-rated health and fertility intentions. Moving to the results. So first we run models by gender. As I said, gamma, the coefficient in the bottom right that you can see the self-rated health in brackets gamma, should be interpreted as the effect of reporting very good health on fertility intentions, net of unobserved factors, plus clearly all the control variables that we have. A positive gamma means that individuals reporting very good health are more likely to declare positive fertility intentions. And at the same time, this means that individuals reporting poorer health status are, on average, less likely to be intentional to have a child. As you can see, reporting very good health is positively related to women's intention to have a child, and this is a significant effect, while there is virtually no effect among men. And these effects hold after controlling for a large set of covariates. So the significant relationship between good health and positive fertility intentions among women persists after controlling for age, civil status, education, parity and employment status, and I'm not showing these coefficients. Plus you can see the coefficient for the duration of stay, and you can see that women who arrived to Italy recently are more likely to be intentional to have a child, controlling for country of origin, and as you can see, men from Africa are the ones who want to have a child the most, and the cause of migration. So you can see men who migrated for economic reasons or affective reasons are more likely to intend to have a child compared to those who migrated for other reasons. And we have this quite strange coefficient about women migrating for affective reason. This group include women migrating for family unification, and I was expecting them to be more likely to have a child compared to the other group, but actually the result, the coefficient is negative and slightly significant, but this will get clearer later in the presentation. Second step, we replicated our models among women and men by duration of stay. So the relationship between good health and positive fertility intention is stronger among, this is only for women. As you can see, the relationship between good health and positive fertility intentions is stronger among long-term migrants, while it is not significant among recently arrived women. And the situation about the cause of migration now, in particular migration for affective reasons, is clearer here because you can see that recently arrived women do intend to have a child actually, and the negative effect that we found in the previous model was mainly driven by long-term women who probably after 6 or more years after family unification have already done with children, and they have on average less positive fertility intentions. Among men, again, there is virtually no significant effect, so I'm not wasting time on this slide. The effect of health is overall negligible. Finally, we ran the last model only among women, and we ran models separated by cause of migration. As you can see, looking at the gamma coefficient, reporting good health is positively related to fertility intentions, especially among women who migrated for economic reasons, even if the relationship is significant, slightly significant, also among women who migrated for affective reasons. And looking at the coefficient for recent versus long-term migrants, the first one, you can see that women arrived for affective reasons are indeed highly intentional to have a child in the next future. Maybe this is the highest coefficient found so far. So to recap, we found that self-rated health is related to short-term fertility intentions, at least among female immigrants in Italy. And on the other side, we found virtually no effect among men. We found a stronger effect among long-term female migrants. And this, I think this is in line with the assimilation hypothesis and with the exhausted migrant effect, because as the duration of stay increases, health status acts as a determinant of fertility, probably because migrant health conditions start to deteriorate. Finally, the effect is particularly strong among women who migrated for economic reasons with respect to those who migrated for affective reasons. And these findings also make sense because those who migrated for affective reasons can rely upon someone else, most probably the partner or other relatives, while among those who migrated for economic or for working reasons, a perfect health probably is a prerequisite in order to be able to maintain the status achieved more than for the others. And for them, bad health hampers fertility. What is important is that our result persists after controlling for a wide array of factors and after controlling for unobserved heterogeneity that was an important issue in this case because our dependent variable and the main independent variable were both self-assessed, self-reported variable and could have been affected by unobserved individual characteristics such as individual attitudes. For this reason, we conclude that health should not be disregarded when investigating about migrants' fertility. And we mean actual fertility behavior, not only intention, because at this point we can assume that health still plays a role besides the commonly investigated variables, including occupation, duration of stay, and cause of migration, for which we controlled in these studies, in this study. And finally, we wonder what are the mechanisms through which health may affect fertility net of all the other factors that we consider. Well, quite simply, women reporting bad health might feel insecure about their physical ability to carry on a pregnancy. And moreover, bad health could attempt women's ability to provide for their children in the future, especially for those who do not have any support networks. Finally, and this would be especially specific among migrants, the poor knowledge of the national healthcare system and the fear related to this may discourage the decision to have a child or another child if not in perfectly good health. So as I said, this was a work in progress, so we are planning to make some more steps. We would like, first of all, to compute and display average marginal effect for a finer interpretation of results. The gamma that I showed here is just the effect of self-reported health on the latent variable behind fertility intention. So it gives us an idea of the magnitude and the direction of the effect, but we are missing some stories about the different effect in each of the 4 categories in which fertility intentions variable is divided. And we would like to use information about the spouse, which is not that much. We only know, I think, the citizenship and only about the spouse, so not about the partner. We have information about the citizenship of the partner only if they are married. So it would only explain part of the story, but still could be interesting. And last point, which we already did partially, is to try to explore differences by origin countries, even if for this latter point, we have 2 small problems. The first one is the grouping of countries provided by the National Institute of Statistics, and the second is the sample size. So dividing our sample by gender and then by origin countries usually results in very small samples that not always allows clear investigations of the phenomenon. So I thank you for listening, and I leave you with my email. As Rosalind said, the same holds for me. Please write if you have ideas or suggestions that we can't discuss here for time reason, and also a couple of contacts for 2 projects that we have at the University of Florence right now. Please feel free to go and explore if you're interested.